Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everybody, we are the Millennial Mechanical Therapists. My name is Joe.
I'm Clay.
And today we're going to talk a little bit about treatment-based classification. So treatment-based classification is a different type of classification scheme that's been around for a while and getting a lot of traction. A lot more research is coming out about it now, a lot of more higher level research and more people are kind of critiquing it. And I think more and more clinicians are hearing about it and using it, and I think it's a good time that we kind of just give you our 2 cents on what we think about treatment-based classification.
So recently in PT Journal, there came out an article that kind of went over the history of treatment-based classification and how it has been developing itself through the research and just through kind of self-critique and things like that, how to make it better and so on, which is fantastic. Awesome. Everything needs to do that. That's great. So we're certainly not going straight at TBC right now.
No, we're not harping on it.
One of the things that, as we read through that article, we kind of came on just this quick stumble point where when you fall into that tier where you will receive rehabilitation services, one of the first things that they look for is centralization.
Yeah.
So to find centralization, what they have in the algorithm, at least based on this research article, is if flexion or extension elicits centralization, right?
Yeah. I think they do have listed some coronal plane movements, but I think predominantly flexion or extension. Mm-hmm. Could be wrong, but at least I think that's what they had in this article.
Right. So almost regardless, that first step is finding that centralization if it's there.
Yeah.
Now, going through that article, and again, mainly the one from PT Journal, it was not very harped upon that it needs to be a thorough assessment of finding centralization. It almost seemed like it was did it work? No? Okay.
Move on.
Next step.
Yeah.
So as I read through it, that's kind of how I perceived it from that article. Now, is that from the horse's mouth? Probably not. It's from an editorial talking about the history of it. So take that for what it's worth. But if that first step is centralization, it means a couple of things. And I'll let you take over on that one.
No, I think it means if your first step is centralization, you're truly seeing if that patient falls into that group of individuals that's going to respond from repeated movements or direction of preference types of exercises, then you need to be good at assessing repeated movements and direction of preference exercises, because a patient, if that's what they truly need, will probably not benefit from a stabilization program or manipulation or anything along those lines. So you should be thorough, one, with that examination, and most likely you probably should learn it from an MDT perspective. And not saying that you need to learn it from that perspective, but MDT, both historically as well as classically, is the assessment protocol that came out and kind of put this in everyone's faces. I mean, these people, those of us certified clinicians and diplomats beyond, are the individuals that are truly looking at repeated movement testing on a very thorough basis, and not just sagittal plane movements, but coronal plane movements, transverse plane movements, and kind of combinations of. Mm-hmm. So you may not do well in the sagittal plane, but if you just pull their hips offset one way and you're parasagittal, you may centralize in a second. I had a patient that was just like that today. So if you're not seeing that and you don't get that result, and you quickly go on and say they must be in another subgroup, then you could be missing something. So while treatment-based classification has a wonderful algorithm, I think it's imperative, if you want to be good at, one, ruling these patients in what subclassification is, you should be good at getting through round one first.
Right.
And I mean, I would say that, not saying that you have to go into this, but you should probably at least take some of the courses and get fairly familiar with how to do a proper repeated movement test, testing exam, and how to make sure that you're, finding that. Because otherwise, then you're going to be moving too quickly, like many clinicians who are not exposed to treatment-based classification, are not exposed to a repeated movement exam through the McKenzie protocol or McKenzie thought process, do quickly. People don't respond fast, and they move on and they lose it. And that can be why some people have poor outcomes.
Yeah, going through McKenzie training and becoming certified, when you get to Part C, Part D, one of the parts of that, I guess, curriculum, when you get there, one of the things they harp on are mistakes that are being made by clinicians. And one of it's not being thorough enough. I think the terms they use is not enough reps, really. And that just kind of goes through the whole thing. So if you're checking standing extension 10 times, standing flexion 10 times, and you don't really see anything, is that enough? That's like if I were to put my hands on someone's back and go, I don't think it's flexed, rotated, side bent, left. But then you get a really experienced clinician to come in and go, well, nope, it is. Who's to say that your palpation skills are anything different than your centralization finding skills?
Yeah. You need to practice them.
You definitely got to practice them.
On everyone.
So I think that's going to kind of round us out for part 1 of this talk real quick. We've got a little bit coming in part 2 here. So
stay tuned. But listen, because I think this is something, we're not attacking treatment-based classification at all. We think it's wonderful. I think most MDT clinicians follow a relative familiar scheme on how they attack patients. Anyways, I think there's good research to back up its use, but I think we need to be thorough in what we're doing and how we get there.
And that's what's coming next time in part 2. We're going to talk a little bit more about that.
We'll see you then. Move your patients early.
You got to move them often.
And move them to line range, my friends, because that's where the magic happens. See you in part 2.